Hello, everyone. This is Rachel Yellen with the Yes to Birth Experience. Today, we are super lucky because we have Julie Bonapace, who is a researcher and educator and the author of the Bonapace Method. Welcome, Julie. It's so nice to have you.
Hi, Rachel. I'm so happy to be here.
Yay. So Julie by education way back when was trained in social work, and she specializes in neurophysiology and pain management. She is an EFT, that's the emotional freedom technique practitioner. She trains healthcare providers in 15 different countries, and I really want to highlight that because she is very much into the non-pharmacological ways of managing pain, and she goes around the world and teaches health providers on how to help women have a better birth experience. So, Julie, I'm going to jump right in and ask you to just tell us what got you into the work that you do, the work as a whole, and then specifically the birth work.
Well, I started all of this as a family mediator and negotiating divorces when I asked parents why they were divorcing. We often came on the birth of a child. So because they experienced a lot of challenges following the birth, a lot of couples were separating. And then I got interested in trying to figure out why this was happening. And I'd ask the mothers, and they'd tell me that they felt tired and overwhelmed and isolated. And I ask the partners, and they tell me, I kind of feel left out. I feel like I'm not part of it. And there's no sexuality or very little. And there's this whole list, and I come at the bottom of the list. So my intention really was to involve the partner. That's my work originally really, and always, even to this day, is to strengthen the couple so that they can face the challenges of parenting in an easier way and together. And so also the research that we have on this is that when partners are involved during pregnancy, they're involved during birth, and they're involved after birth. And when they're not involved, traditionally we used to tell partners, you need to be out of the birthing room, and you don't know anything about birth, and you don't know anything about taking care of the children. So when partners aren't involved in educating and parenting the children, they're more at risk of a divorce. So really the reasoning behind the program that I developed was to empower the parents. But then, imagine if as a social worker, I'd tell them, why don't you come to group therapy, and we're going to discuss the challenges and help you face the crisis that you'll have in postpartum. They're going to say, I don't feel that we need any help, right? So I addressed the most urgent concern that parents had in pregnancy, and it was pain. And it just so happened that I practice a lot of extreme sports. So I rock climb, and I kite surf, and I whitewater canoe, and I practice a lot of sports that require a lot of focus. And throughout all of these sports and through yoga, because I became a yoga teacher about 30 years ago. So through these techniques, through these practices, I developed the techniques that really help to focus the mind. So when you're scared, or when you're in a situation of pain, how do you overcome these sensations? So that's how I put together my program. And then through the research that I did in a pain management lab, we really went deeper in understanding the mechanisms. And basically that's what I'm teaching in hospitals all over the world, and to doulas and to parents. It really is how to activate the resources that we have.
So tell us, of course, the biggest thing, you ask, you do a poll on, women's biggest concerns for pregnancy, and they say the number one thing is their fear of the pain. So why, it's always fascinating for me, as somebody who's been to hundreds of births, and, why do some women say, like, yeah, it was totally fine. It was totally manageable. It just felt like it was some stretching and some pulling. And other women say it was excruciating. It was the worst thing. Can you help us understand that better?
That's a really good question. I've just published with the Society of Obstetricians and Gynecologists of Canada the guideline on non-pharmacological pain management. And one of the topics that we address is the origins of the signal. Why is there pain? And actually, there is no clear origin. So if you have an accident and you cut your hand, the origin of the pain is from the lesion. But in birth, there is no lesion per se. Nothing is breaking, right? So your pelvis is not breaking, and you're not tearing your uterus in normal context, right? So what is the origin of the pain? So the physically, we can say that nociception, or the origin of the pain, can be related to the stretching of this tissue. Like when you're doing a yoga pose and you're going deeper, you're going to feel some stretching. So it could be that. It could be some pressure, depending on how the baby is positioned in the pelvis. It can be some pressure that's exerted in some section or another. But what we know now is that the psychological component of pain, which is called pain unpleasantness, and the emotional aspect of pain, is something that will increase by 1,000 the sensation. So depending on what's going on in your head and what you're telling yourself in your head, it can increase or reduce the pain. And this is where in our society we've really gotten it wrong, because we're depicting a powerless woman, a woman yelling, being probed, being touched, being disturbed. Never a woman who's zen or happy or experience orgasm, ecstatic births. We never see that. And so women are conditioned to believe that it's going to be painful. And because they're expecting it and anticipating it, they're increasing the unpleasant signal in whatever contractions they'll have. And even in the terms that we use, like contraction, if we called it a wave or a surge or a rush or a sensation, it would feel a lot less uncomfortable. So I would say that historically we have a lot of blocks that are created by our culture. And that's why it makes the experience so traumatic for many women. There's also another aspect, is that since birth has gone into medical communities, so in hospitals, it's only been about 100 years in many countries. We've treated the birth is treated as a sickness, a disease, like something that's going to happen, something dangerous that's going to happen. And so a woman is treated with a lot of interventions that will increase the sensations. So many countries where I work, women are induced into labor. So when you induce labor, you're going to increase pain because you're inhibiting the natural hormones that reduce pain. When you stop women from eating and drinking, as they do in many countries, you're also going to increase pain. I mean, if I don't eat for 24 hours, I'm going to be in pain, right? And I'm not even laboring. So stopping women from moving because they're connected to monitors, or they have beeping sounds or clocks that are activating their mind, is also going to increase the signal. Having vaginal exams every hour, 2 hours, 3 hours is going to increase the sensations. Having people come in and out of your room is going to increase pain, right? So there are a whole bunch of interventions that occur that increase pain. And so this confirms what the birthing person is believing. So she was taught to believe that it's painful. She has these interventions, they're painful. So it confirms equals, yeah, it's painful. And then there's the anticipation of it. And the more you anticipate, the more it's going to create pain. So there's this whole cycle of culture that we need to work on. And that's why we say before pregnancy and during your pregnancy, take time to remove these blocks, the blocks that may occur to create the fear inside of you, the fear that you can't do it. Surround yourself by people who believe in you, who believe that you can do it. Prepare your body physically, prepare yourself emotionally and psychologically and spiritually, so that you can be in an environment that's going to support you. Because the environment is going to be for at least 50% of the equation. So if you're in an environment that's zen and people, love you, respect you, take care of you, you're going to experience a lot less sensations. And if you're not feeling safe, you're going to experience a lot more.
Totally. Julie, I'm thinking of so many women, who come to my classes. And when I start talking about some of these things that you're mentioning, which I'm so grateful that you laid it out so clearly, like these are the things that we see in this birth room that create more pain for women. Mm-hmm. And I see a lot of these women, and they say they get it. They get it intellectually as we talk about it, but there's that, it's almost like well, what do I do now? And I'm wondering if you can speak to, okay, I get that. Like a vaginal exam is not going to help me be able to focus inward and trust my body and relax. But now what do I do with that?
Mm-hmm. So that's a really good question. And there's a lot of work that's being done. Deborah Pascali-Bonaro worked on the women's rights and having respected rights for both the baby and the mom. The first thing we need to know is that we're allowed to say no. I mean, that's the first thing we need to get to. This is our body, this is our baby, and this is our life. So basically, we're allowed to say no. But it creates, if you're not in a good birthing environment, it creates a lot of tension, and you need to be open. And it's hard to be open when you're tense and you're fearing, why are they going to do this? Why is this happening? So if there's any way of being outside of the birthing environment, the traditional birthing environment, I think the births need to go back to a more natural physiologic environment. What I tell birthing parents, if you can't choose to be birthing at home or in a birthing home, then and you decide to go to the hospital, try to at least have a doula that will support you and your partner, and try to do as much laboring at home. Because once you're in the official site, you're going to be, it depends, but you're going to be confronted with a lot of interventions. And I think that definitely the more that we tell parents, if it's gone wrong, then we have to start doing we have to take legal measures. We need to do that because in many hospitals, they feel that when a woman comes in and she signs her admission to the hospital, that she's giving up all her rights, that she can't choose anything. And yet what I teach in hospitals is that every single intervention that we do to women should have a consent form. So consent that I'm inducing, consent that I'm giving an epidural, consent that, that women are aware of all the benefits, the risks, and the alternatives that exist when they have an intervention. So that's a way of reducing that medical, let's say, part of interventions.
So let me just, sorry to jump in. One thing that really comes up for people as they're making choices about where to give birth is how do they say, well, I went for the hospital tour and the person, guiding the tour was so awesome. And they said all these wonderful things. And then I'm sitting here thinking, but that person doesn't even work at the hospital, or maybe it is a labor and delivery nurse, but what questions, what are like your top 3 questions for people when people are searching for where to give birth? What should they be asking, not just on the tour, but how do they get the real data and the real story about what's occurring in the hospital in general, and then within the practice that they have chosen? And that practice may have 6 providers or 10 providers that are on a rotation, or with each individual practitioner. What are the top questions to ask to get real clear about this?
Well, it's very difficult. You see, scientifically, it's been proven that what reduces interventions and creates safety is continuity of care. So continuity of care means that you have the same person that's with you during pregnancy, during birth, and after birth. That's why the midwifery model of care is the best model in the world. It's the cheapest and it's the safest because there's the trust that's built between the mother and the midwife. So we have to say the real things. When you go into a hospital, it's gambling. You're gambling because you don't know who's going to be there. So you could have the really nice nurse, or you could have the midwife or the nurse who hasn't slept for a week and who's just overwhelmed with work. And the midwives and nurses in many hospitals are just overworked. So this model doesn't work. There's too many people that the same healthcare provider has to take care of. They're burnt out. I can tell you in all of the countries where I've worked, there's a high level of burnout in the healthcare providers because the model doesn't work. We have too many women in one spot being taken care of by one woman or one professional. So in Algeria and Morocco, where I work, there is 65 to 135 women who labor in 24 hours, and there are only 6 midwives. So women die in these contexts because of lack of care. So these women would be a lot better off at home, where they have their partners, their sisters, their mother, someone taking care of them. So you see, I'd say the setting is really important. The other thing that you can do is question on, I always look at the rates per hospital, and this data has to be available everywhere. So you look at the data for the hospital, but there's also a big variability in the hospital. So you could have one physician who has 10% rate of cesareans and another physician who will have a 90% rate. I mean, I was working in Lebanon, and there was a doctor who he had pride in telling us that he had 100% rate of cesarean section. So if the rate in the hospital is 40, it was 60% in that hospital, but there was a doctor who had 15%, right? So you can't even rely on the data from the hospital. You need to have the data from the OB, right? And then you don't know exactly who is going to be the OB. So I don't think that model of care is the ideal model for laboring women, really. But if I were, I would ask questions, but then again, there are many women who have asked. They have publicity out saying this is a natural birth facility. We listen to your desires and your needs, and you can labor in the position you want. You can give birth in the position you want. And yet when women try to do that, they're told that it's not possible, it's not safe, they're not comfortable, it's not something that we do, and we have protocols. And so I don't know, my idea is we need to get births out of hospitals unless they're high-risk births. So I don't know if I've answered that well for you.
And you've articulated it really beautifully and cleanly. And what you're talking about is based on a tremendous amount of evidence, not only that you've researched, but where you have seen this in many, many different countries, and where we know that we are doing, particularly, I'm in the United States and I know you're in Canada, but we're in North America in general, we're doing a very poor job of providing safe births and happy births.
Mm-hmm.
And of course, we have huge rates of postpartum depression, and huge rates of mothers not being able to successfully breastfeed their babies, and so we've got a lot of issues. So I wanted to ask, what resources, what resources do we have?
Well, for pain management per se, we have a lot of resources that are hardwired in our body. I mean, we've survived over tens of thousands of years in conditions that are very difficult. I come from northern Quebec in Canada, and it's typically minus 35, about 25 days, 30 days in the year. And you think of the First Nation women who labored and gave birth to children and large families in those conditions, I mean, without electricity and without, commodities. And we survived and we thrived as a population all over the world. So there has to be something that we do right in labor, right? So these resources are hormonal and neurophysiologic. So to cope with sensations, we were given hormones. And hormones that are produced by our body are there to help us experience ease in labor. So that means that they reduce pain. We have hormones that help us feel love and attachment towards our baby, and that ensures that we take care of our children, right? So the problem, and I'm sure you'll have someone speaking to this in your summit. But the problem is medical interventions, they interfere with the normal course of our hormones. And that's why we have women who have trouble breastfeeding, who have postpartum depression, who have attachment problems. It's related to the fact that we're giving them drugs the epidural or synthetic oxytocin that is going to inhibit and modulate the natural hormones that we have. And that is bad because we haven't even researched entirely what effect it has on the newborn. But now we're seeing that it's having an epigenetic effect. So it's changing the genes, the expression of the genes of the newborns. And so we have to stop messing with this. We have to stop doing things just by commodity and really start respecting the physiology of birth.
How does it change the genes of the baby? What does that look like?
Well, I'm sure there's specialists. Sarah Buckley will be able to answer this better than I will. But essentially what it is when you're giving synthetic oxytocin to women in labor, the endogenous resource, the natural oxytocin that we release from our brain, is shut down or diminished because you have the synthetic oxytocin, right? So it's circulating in your body. And so the brain is saying, well, I'm not going to produce anymore because there's a lot. So the problem with the synthetic oxytocin is that it doesn't cross into the brain, it doesn't cross the blood-brain barrier. So it doesn't go into your brain. So it doesn't have the emotional, feel-good, love sensation that you have with the normal hormone. And this normal hormone is because you're inundating the baby's system during birth. It has an effect on the baby's ability to produce his own hormones. So we don't have all the answers on this, but we're definitely getting some information now where we're seeing in young children difficulties like autism, depression, suicide rates, things like that are pretty alarming. They're difficult to correlate, to say, oh, it's because of this that this happens. So that's correlation that's difficult to make. But we're definitely seeing a lot of psychological fragilities, with young children now. So I think that this is something that needs to be addressed.
Okay. So is there any other pieces that you want to say in terms about these resources that we have before we move on to some of the techniques and the ways that we manage everything?
Absolutely. So the other resource that we have, it's neurophysiologic. So you see, in any context of pain, let's say you have a knee injury, there are some resources. First of all, the knee injury, the pain that you'll be experiencing in your knee, is there to tell you to do something. It's guiding you. It's saying, well, don't walk on your knee, do something about it, put some ice on it, do something, right? So it's pay attention. Pain is there to warn us, to tell us something's happening. Yet in childbirth, what is pain or sensations? Why are they there? First of all, they're there to tell us, go to a safe place. Because imagine if you didn't feel anything, you probably would give birth while you're doing your groceries, right? And that could be dangerous, right? Because you could be in an environment that's not safe for you or the baby. So the sensations that you're experiencing are just telling you, go somewhere, do something, okay? Find your tribe, find your people. So the sensations that you have are also telling you how to move, what to do. So in birth, and in any other context, there are three mechanisms that will guide you in reducing the sensations. The first mechanism is called the gate control theory, and it's a theory that was developed in the 60s by a Canadian researcher and an English researcher. And what they discovered is that when you caress, when you lightly massage the painful area, you're going to reduce pain. So if you have a sore knee, you're going to rub your knee, and that's going to feel better, right? So by rubbing, you're blocking part of the signals that go to the brain, and that's a way of reducing pain. So for a laboring woman, if she's experiencing sensations in her back, what she could do, or what her partner can do, is just use some water. So you can just use a shower or a bath, take a bath, and while you're bathing, you're caressing the painful area. So it's the way of using the gate control. So you could do a light massage, you could vibrate, so move her, if she has problems in her back, you can move her buttocks or move her thighs, vibrate her thighs. You can caress that zone. So when you're caressing the painful area while you're experiencing pain, you're blocking part of the signal. And this is something we do naturally. When a child hits himself, we will rub the sore, we'll kiss the sore, and it's a way of creating a non-painful stimulation of the painful area. So that's the gait control. And there are a lot of techniques also moving, ambulation. So swaying, rolling on a ball, moving your back, and that type of massage will also help. The second mechanism is called, it's a bit technical, but it's called the diffuse noxious inhibitory control mechanism. So it's what we call the DINIC system. And this is kind of like a counterintuitive mechanism. It's related to creating a second pain. So when you're experiencing, let's say you have a sore knee, you're having a lot of pain in your knee, and you create another pain somewhere else. It can be anywhere. So you'll press on an acupressure point in your hand, or you'll bite your lip, or you'll use anything else that would create a second pain. What happens is that your brain is going to receive the second signal, and it's going to want to understand why there's a second signal and know if this second signal is more important or different or dangerous from the first. So temporarily it releases endorphins, a neurotransmitter that will block the first signal, so the pain in your knee, and it will just maintain intact the second signal so it can analyze the second signal. And you see, we use this spontaneously. For example, if you hit your finger with a hammer and you bite your lip, when you're biting your lip, you're creating the second pain, and it reduces the pain of what you're feeling, from the in your thumb if you hit your thumb. So it's this notion that when you create the second pain, you'll be producing neurotransmitters, the endorphins. So how do you use this in labor? Well, in Algeria, women traditionally, they'd put a rock in their hand, a little stone in their hand. And when they'd have a rush or a contraction, they would squeeze the rock. So squeezing the rock would create pain in their hand, and that would reduce the intensity of what they're experiencing in their rush. Another technique that you can use is just having a little bucket of ice. And then you have your rush. When you start having your contraction or your rush, you put your hand in the ice. And then after a few seconds, it starts creating a second pain. And that second pain is going to reduce the first. So you can also use acupressure points. So some points have to do with creating contractions, facilitating the dilation of the cervix, maintaining the energy in the mum. And so when you find these different points, you can just apply a strong pressure once the contraction or the rush is well established. So if the woman says, now it's intense, you create a second pain. And that's a mechanism that works tremendously well. You see, my colleagues and I, we published a large study with 34,000 women. It's 57 randomized controlled trials that we put together in a review study. And we demonstrated that if you caress the zone, so you use the gait control, you'll reduce the level of epidurals by about 20%. But you won't have a lot of effect on the other interventions. With the DINIC, so creating the second pain, you're going to reduce the rate of epidurals about 40%, and you're going to increase satisfaction. So it's a mechanism that's more robust, but you can use both of these mechanisms together, right? So there's a third mechanism, and the third mechanism is the most powerful mechanism, and it's called what we call the control of the mind, or deviating attention. So in our brain, we have the capacity to produce a neurotransmitter, again, the endorphins. Endorphins are the substances that reduce sensation, right? It's kind of a type of morphine that really makes us feel good. And mentally, we have the ability to produce this. It's just that we've kind of forgotten how to do it, but we can definitely produce this neurotransmitter. And what this mechanism is that when women feel safe, when they're in an environment where they feel uh, that they're protected. They produce the neurotransmitter. And in this mechanism, every time that anything that has to do with your cognition, with your mind, will be part of this mechanism. So you were mentioning that in your approach, you use hypnosis or self-hypnosis. So self-hypnosis, relaxation, mindfulness, visualization, cognition, all of this is part of that mechanism. Breathing, it's everything that's focusing the attention. So depending on where you're focusing your attention. So if you're saying, I'm doing well, I'm opening, I'm letting go, I'm working with my baby, you're going to have less sensation. You're going to produce the hormones. You're going to produce the hormones and the neurotransmitters, the endorphins. But if in your mind you're saying, I'm dying, I hate this, I want this to stop, I'm scared, what if? You're going to produce stress hormones, and you're also going to produce you're going to inhibit the production of the endorphins. So depending on what's going on in your head, it's going to impact how you're going to experience your rushes. And this mechanism, when we tested it with the 34,000 women, with this mechanism, when women activate this, they reduce by 60% their chance of having a cesarean. They reduce all medical interventions, and it also reduces pain and sensations. So when we finished this study, I was working in hospitals, and one OB came to me and he said, if I understand correctly, if we treat women well, they'll have better births. It's like, well, yeah, exactly. That's exactly it. It's a no-brainer, but it's something that is really neglected a lot. So we really need to have partners work with women to support them, to support their environment, to support their choices. And if they see that there's neglect or there's a lack of respect, then they need to correct that. The partners need to correct that, because women in labor, I mean, we're supposed to be open. We're not supposed to be fighting. And if we're fighting, then we're producing the hormones that are counterproductive to what we're supposed to be doing, which is opening.
Totally. You've articulated that so beautifully. And I feel like our listeners and whether you're, for our listeners, whether you're pregnant or whether you're a birth worker, there's so much takeaway here. One thing, Julie, that I know we need to get into this is the EFT. Can you just share just a little bit? Because I'm assuming that that's in the third category, right, of technique, in terms of the mind. But can you just say what is EFT and a couple of examples of how to do that?
Absolutely. There's an excellent website. It's called EFT Universe. There's also a part on childbirth there. I produced a video with Dawson Church, who's the founder of EFT Universe. And they can, if they want more details on how to use EFT during pregnancy and birth, they can go to that resource. So what emotional freedom technique, what that does is that typically in a context of stress, we produce cortisol. Cortisol is a hormone that affects our well-being. It also affects the course of labor because it's part of the stress hormones. So EFT is a way to eliminate stressors. It's a way to reduce the stress hormones that we're living. And there's this whole formula that can be used, but what I teach partners is to help women tap and talk. Because what happens if you're only going to be talking about the problem? I'm scared, I'm so scared, the baby's not descending, I'm tired, I don't want to do this, and you keep on repeating that message. You're hardwiring the message, and you're creating neural bundles. So you're increasing the facility with which this signal goes. So it goes from bad to worse to worse to worse, because the more you say it, the more you're going to increase that signal. So what you want to do is reduce the signal, because once you've reduced it, you're able to open up to other options. So tapping is based on talking and activating acupressure points. So why do we do talking and acupuncture together? Is because we realize that if we only do the talking, we're hardwiring it, and we're hardwiring the negative, which we don't want. But when we tap, a psychologist in the US in the 80s discovered that when you tap, you're activating the energetic system in your body. And these points are related to creating calm and focus in your brain. So you could just tap. You tap on a point. So this is a point that's on the side of the hand, and it's called a karate chop. You could just tap on this point. There's a whole other sequence that people can go in and find out more about, but you tap. So whenever you're in a very stressful situation, or if a woman is laboring and she's experiencing, anxiety, which is something that's extremely frequent during pregnancy and during labor. So it's to tap and talk. So I'm so scared. I'm really scared. I'm scared about this. This is disturbing me. I'm so annoyed, and this, and just doing this is going to reduce the cortisol. So that would be, let's say, step one. I always teach the partners, don't tell women what to do. Don't tell them, it's going to be okay. Don't tell them, don't worry about it. Don't think about it. Just let them express it. So, even though I have all this fear, and this is the opening sequence, we'd say, even though I have all this fear, I choose to love and accept myself. And we repeat that. And then we could go on tapping all the other points. I don't think I have enough time to explain all the points, but these points will help reduce intensity, anxiety, stress. And step number one is to release it. And then eventually you start opening up to, okay, I have all this fear. Why do I have all this fear? This fear comes from here. I have this, I have that. What can I do? And then you can start finding, it creates space for you to find some solutions. But the most important thing in labor is to release. So you need to release the intensity of the emotions. I'm feeling overwhelmed. I'm not going to make it. I'm not going to make it. I'm not going to make it. So just release it. But don't just release it without tapping, because if you're just talking, you're going to hardwire it. So people could just tap like this and then talk.
This is so incredibly useful, not just for somebody who's giving birth, but for people who are in the birthing room, who are birth providers, because the level of anxiety and fear that they experience is quite high, and they're often not able to address their own concerns because they're just on autopilot of having to get all these things done. And so this is a way that you can move and, be, doing the tapping simultaneously. So I really appreciate that teaching.
There's also another thing that I'd like to share. It's very simple, and it's chanting a sound. So you see, typically in labor, this is the work environment for nurses, for doctors, for healthcare providers, and they come in, they come out, and sometimes the sacredness of the environment is forgotten. So by singing this sound, it creates a kind of like, oh, what's going on? It kind of feels like it's a mass, right? It's a ceremony. There's a ceremony that's going on. So I teach parents to sing the hue. It's a sound. So it's like hue, and it's spelled H-U. And this sound, first of all, it releases the diaphragms. So it makes that you create more space in the body for the baby, because your diaphragm, the breathing diaphragm, can raise and come down, and then can rise and come down, and then the diaphragm from the perineum comes up and down. So when you're singing it, it automatically all happens.
But
so it's a way of,
I feel compelled to do it right now. Can we just do it together for a second?
Yeah.
Everybody who's listening, we can all do it together. So you just take a big breath in through your nose, and then just the HU sound. So we just Oh, I feel that, especially towards the end.
Exactly. So the diaphragms, they move. And
Yes.
when you tell women, oh, you need to move your diaphragms, they're like, oh, how do I do that?
Yeah.
So we just sing this sound. And it's also a way for the partner to see if the woman is, breathing, because when we're scared, what we do is we hold our breath.
Right.
And when you're holding your breath, you're creating a tense environment. So if you sing, you're releasing the diaphragms, you're also aligning. You feel that, oh, I feel like all my energy is aligning. So this creates a feeling of calmness within. And it also creates an environment that's calmer. And when people come in and they hear that there's this sound, they're going to like, oh, they're not going to talk loud. They're going to
Mhm.
kind of respect the sacred space that you've created. So I find that with the EFT and the singing the hue, it creates this more favorable environment
Right.
for the parents.
Right. And also, as you know, with this, what I notice is that the hue sound, as I did it, of course, it's lengthening my exhalation tremendously, which activates the parasympathetic nervous system to say, oh, right, she's relaxed and she's safe in that lengthening of that long exhale. That's so awesome. Julia, I feel like I could talk to you forever. You've provided so much information for us. I really want to take a moment and ask you to direct people to your website and to share. You have a very generous, you have a lot of availability and generosity to offer our listeners. So if you can share where they can go to find you, to learn about the Bonapace method, to access the resources, and how can they reach you?
So I've offered a 30-minute free consultation. So a consultation to discuss whatever challenge that you're experiencing in pregnancy, during birth, or after birth. So people can go to my website. It's bonapace.com and sign up
Spell that
there.
for us, because I know you're half Italian, half Lebanese, and people may not know how to spell your last name.
So it's Bonapace, so BONAPACE.com.
Great. Great. So to thank you so much for that generous offer. So appreciate that. To bring us home, when we were speaking yesterday, you were telling me that you were at a birth recently, and I won't. You'll share what you want to share about that, but it was such a powerful experience that I heard you say, and I'm wondering if you would be willing to share some of that with our listeners.
Sure. My daughter just gave birth and she authorized me to share this with everyone. So she just gave birth a couple of months ago and she had a home birth. It's a first birth and she was well prepared with her partner. And of course, she also teaches with me. So we're, aware of, and we've been teaching all of the comfort measures that exist. And there's one tool that's underused, and it's sexuality. So my daughter and her partner had trained in using these techniques. And the first non-pharmacological method that she used was an electric toothbrush. So during every rush, she masturbated using the toothbrush. So she used the vibrating side of a cheap $2 toothbrush. We actually had to change the batteries twice. Because she used it during the whole duration of her labor. That was about 24 hours. And so through every rush, she just asked her to have her hand out like this. Okay, I want my toothbrush. We give her toothbrush, and then she just have that on her clitoris. And throughout labor, it was like she was flowing and dancing and chanting and moving and swaying. And they also made love, and they had oral sex, and these are all things that you're like, oh my God, is that even possible? And I, as a parent, she invited me to participate. And of course, when it was time for us to leave, because they wanted to have intimacy, they just get us out of the room and did whatever they wanted to do and call us back when they needed us. So I think that the more that we can get back into the flow of this and understand that labor and delivery, and it shouldn't be called like that, but birthing our children is something so transformational. It can be an empowering, beautiful experience. And it's yes to birth, right? It's yes, we can do this. So we've forgotten that we're goddesses, and we need to remember that, and our partners need to honor that, and they need to help us express that. And we do that by preparing. So prepare, 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 because we have to fight the culture of fear. that's been pervasive in the last 300 years, the fear of birthing. So we need to re-empower ourselves, take back our births.
Thank you so much. And please extend our thank you to your daughter for being probably not just willing, but excited to have you share her experience. Because one of the things we know is that women are not sharing their positive experiences enough for fear of making other people feel badly. And so I'm so grateful that she was willing to have you share that. Julie, it's been wonderful to be with you. So all of you Yes to Birthers, visit Julie Bonapace's website and call on her. As you can see, she's got a tremendous wealth of information and knowledge and experience. And we are very lucky to have had her with us for the Yes to Birth experience. So I'll say goodbye to all of you, and we'll see you soon. Thank you, Julie.
Thank you.
I am so happy that you're a part of the Yes to Birth movement. Please visit yestobirth.com to learn more about my pregnancy, birth, and beyond audio relaxation program, my childbirth education and techniques programs, and my private counseling and coaching. Yes to Birth. I'm Rachel Yellen. Bye.